Yeah. Hello.
Good afternoon, everybody. David's kindly introduced us. Rebecca and I thought we would try and do something a little bit more interactive, and Rebecca does also need to leave before the panel session. So if you do have any questions, we are actually happy to answer them if they're within our 30-minute time scale. Just picking up on the last slide from Mike, we are glass half full people, aren't we, Rebecca? And as the curriculum lead for geriatric medicine, I have to say I've been incredibly lucky in having fantastic support and interaction from my trainee colleagues. So, Rebecca, do you want to just say a little bit more about yourself in this sort of process of developing the curriculum?
Yeah, so I think Sue and I are from almost opposite ends of the UK, but we came together very romantically over an SAC board talking about the geriatric curriculum. So I was a BGS, British Geriatric Society trainee rep, and was then involved in the SAC of going through the curriculum. And I guess like what I wanted to emphasize was actually how much trainees were involved. So certainly in geriatric medicine, for example, there was myself and a number of other people that then this spanned over 4 years, so there were different representatives offering different opinions, and all of that was fed back even to a local level. So I do think that within each specialty there has been a lot of trainee involvement. I would really echo that.
And I think we all recognise that change is always challenging, isn't it? And change sometimes makes us apprehensive. But I think both of us intrinsically believe that the new curriculum is a better curriculum, and it's a better way of assessment. So we hope we will be able to allay some fears and persuade you of that for the rest of today.
Can I just say as well that if people do have anything like while we're going along, we deliberately put less slides. We have a lot more we could say on the matter. So if there are any questions as you go along, please do ask.
We initially had the question why in our brief today, but I think the previous speakers have clearly elucidated the reasons why the curriculum should change. There are generic changes, as we've heard, to all curricula. And as Mike has mentioned, there are a smaller number of higher level learning outcomes. Now, I'm hoping that everybody here and online has at least looked at their own curriculum and the internal medicine curriculum, so that you will be aware what we're talking about when we're talking about capabilities in practice, because I haven't gone through each of those in this presentation today, but we will expand a little bit more on those. But one of the key things that has changed is that they have replaced that very long tick box of the previous curriculum on the e-portfolio. We're moving more towards holistic assessment of how trainees are doing. So rather than focusing on specific tick boxes, it's much more aligned to how are things going in the workplace. Do you feel able to lead that acute medical take? Are you able to run an outpatient clinic? Rather than, can you tell me exactly what all the 40,000 causes of falls in a frail older person are? Can you put that into practice? It does mean that as educational supervisors and trainers, we are more and more asked for our judgment about entrustment levels for our trainees that we are working with. And I think as we will bring out, and subsequent speakers will also bring out, that link between the educational supervisor and the trainee is becoming ever more important. And that is something that both as trainees and trainers, we really are going to have to invest some time in. We will show a little bit how the progression of competencies, capabilities and entrustment levels will develop throughout training. Now, the internal medicine grid that we will show perhaps doesn't have as clear progression, and that you start at quite a high level. You've only got 12 months left in IM stage 2, but for our specialty curricula, in the ARC-P decision age, you will see a much more obvious progression between where you start in ST4 to where you complete training, be that in ST7 or 8.
Well, I just say for that, that
Yeah.
if people do want to look at that and they're not familiar where it is, if you look at your own specialty or the IMS2 decision aids, which you can just search via Google, you can see them at the bottom. There's a table with numbers from 2 to 4 in them for each part.
Now, Becky and I are both geriatricians, so we haven't focused on geriatric medicine. And when we spoke with Mike and Zoe earlier, we were asked to bring out a little bit about the generic professional capabilities in particular, because I think people are a little concerned about how we might evidence those. And hopefully Becky and I are going to chat about some ways in which we might be able to do that. So although some things have changed, there are quite a lot of things that haven't changed. Mike mentioned we haven't thrown up all of the syllabus for physicianly training in all of our specialties. Most of the syllabi are actually very, very similar to what we've already been using before, and certainly that is the case in geriatric medicine. The underlying syllabus, what you need to know about geriatric medicine, has changed very little. It's more about the way that we assess good practice. So what has not changed is good supervisory practice, that good link between educational supervisors and trainees. Mike mentioned the ARCP process. That too hasn't changed. There will still be an annual review of progression in training. And we also haven't changed our use of supervised learning events and workplace-based assessments as a means for providing at least some of the evidence that will still be helpful in assessing your capability level. So Becky's just going to draw out one or two of the differences between the previous curriculum and the one that we'll be moving to later this week.
Yeah, so I think I'm a very visual person. I think like it can be a bit overwhelming to kind of picture what it might look like. But the things that are the same are that there was the GIM and special decision aids. Now we have the IMS2 as well as your speciality decision aids. So there are still 2 decision aids that trainees will need to look at, but they are different in their expectations within them than it were previously. Previously, on people's curriculum, they might have to click for a GIM one as well as their own specialty, whereas now it all sits within one online curriculum, and I'll show you what that looks like in a minute. There are still the same kind of assessments that you are familiar with, as we said, although the numbers are different from the previous decision aids. As we've talked about, the timings changes, so in the new curriculum people will start at ST4. The main difference is about the capabilities in practice and entrustment levels. Does everyone here feel happy with what they are, or shall I? Yeah, everyone feels comfortable with those. So I think that, you know, even if you're a glass half empty kind of person, surely no one can feel sad about the fact that you have to wait for an hour for your portfolio to load down all the things that you've linked, and then you lose your place on the page. Like, hopefully that will be a thing of the past. So we've got the overall capabilities in practice, as we said, thinking about someone holistically. So the capabilities in practice are more of an overarching statement. So can manage an acute take, can manage a patient's and unselect patients in outpatient clinic, for example. They're much more of a broad understanding of a patient person, and then the entrustment levels are different to how the rating used to be. So the capabilities in practice, or the SIPs, are grouped into 3 categories. So there's the generic, which are linked to the good medical practice and GPC frameworks. And these talk about ethical things, legal things, research, patient safety. There are the internal medicine clinical ones, and they cover clinical tasks which are essentially internal medicine, acute take, for example, and including things like palliative care within them. And then there are the specialty ones. And how this looks is that there are 6 generic SIPs. There are 8 clinical SIPs, and in terms of your specialty, there are different numbers, but in geriatric medicine, for example, there's 7, and some of you will have the additional theme for service SIPs within your specialty as well that you need to do. So this is what it will look like in your curriculum. I think the most common question I would get asked by trainees is, will everything get pulled over? And the answer is no, but that you will still have access to your old curriculum, and what people will need to do at the beginning is will need to, with their gap analysis and in their first educational supervisor meetings, will need to, bring forward some of the overriding themes of what people have in these areas. So when you'll be able to click on your portfolio, you can see that you'll be able to click down and see the different SIPs that you have for each thing, and the practical procedures will come up separately.
So we've talked about this concept of capabilities in practice, and to help us, guide us, I think, towards what sort of experience and evidence that the trainees need, we've broken these capabilities down further into 3 different areas. First of all, there are descriptors which indicate the level of knowledge, the skills and the attitudes which need to be demonstrated for each of these capabilities. Secondly, there are links to those GPC framework domain links. And thirdly, there are some suggestions as to what sort of evidence you might collect to be able to help you and your educational supervisor agree the level that you're working at. The other thing that has changed is that we are asking trainees to self-assess, if you like. So when you're speaking with your educational supervisor, it's really important that trainees have thought to themselves, well, what level of entrustment do I think I'm working at? And then you can get the same opinion from your supervisor and work out whether you're close together or not. And I think that's a slight difference. You've done it with the MSF before.
There was ranking, I think, on some people's portfolio, but it fit slightly differently, and you had to show where you prove where you met it on the previous portfolio.
So from the point of view of evidence, because I think we've had quite a lot of questions about evidence and what might include, there are no long lists of tick boxes, thank goodness. We're both very pleased about that, but most of the evidence that you might collect is very similar from the evidence that we're using at the moment. So SLEs such as mini CACSs and case-based discussions, ADOPTs, workplace-based assessments, they will all stay the same. ACATs, all of those are the same that you're familiar with. Many curricula have suggested courses. Now, increasingly, the GMC are asking us not to mandate things unless they are absolutely necessary and cannot be provided in any other way. But it may still be that, for example, teaching skills are still best obtained or evidenced by going on the trainer's course, so not a specific course, but a course that will give you those skills. But it doesn't have to be that course, it could be other evidence, but it might be easier to collect it in that way. Becky's already mentioned that your evidence will all still be there. Curricula have changed before, and the evidence never disappears. So the evidence will always be there, but if you can help signpost that for your educational supervisor and for those on the panel at the ARCP, that will be very helpful too. And I think one of the key messages is that regular meetings with the educational supervisor is going to be really important in this process. One of the really big changes for us, perhaps as educational supervisors and trainers, is that the assessment is going to take the form of asking at what level trainees are working. Now, we have done this to some extent in our previous educational supervisors report, but this is a little bit more standardised. And there are going to be 2 types of global assessments. One is for the generic professional capabilities, the generic SIPs, and one is for the clinical SIPs, both the internal medicine SIPs and the specialty SIPs. So for the generic SIPs, you're going to be asked to assess trainees on these global anchor statements. So is the trainee meeting expectations for their level of training? Or are they struggling a wee bit and below that, and we need to identify areas that extra experience and skills are required in? Or are they performing above what might be deemed to be expectations for the year of training? So those are for the generic SIPs. For the clinical SIPs, this is about entrustment levels. So what can you trust your trainee, your colleague, we talk about trainees, but it's really the same for all of our colleagues, whether they're nurse practitioner colleagues or AHP colleagues. At what levels are they able to provide clinical decision making? Level 1 is not really mentioned in any of our curricula. That's really a clinical sort of observer type position. But levels 2 to 4 are embedded in all of the ARC-P decision aids. So level 2 is where a trainee will often start moving into ST4 at a specialty level. So they need quite a lot of supervision from senior colleagues, be that a consultant clinical supervisor or more experienced registrars, or indeed other members of professionals, allied health professions who might have more experience in that level. By level 3, trainees are doing what they're doing probably with the acute medical take when they start, which is that they can pretty much get on with it, but they need us to be around and to be available to answer questions on a pretty easy access and rapid basis. And the key one here is going to be level 4, an entrustment to act unsupervised. That means that you are ready to fly as a consultant. So once you are given a level 4 for any SIP, that means you are ready to become a consultant in that particular capability. So at the end of training, by the time of CCT, you should be level 4 or independent in all of the capabilities in your own specialty curriculum. And this is just an example from the internal medicine ARCP decision aid, but a very similar grid will be present in each of the curricula. As you can see, for internal medicine, trainees have already done a lot of training. They've had a lot of experience in IM through the through the 3 years of internal medicine. So they're entering ST4 being able to do most things with little hands-on supervision, but needing a wee bit more direct supervision, managing acute care within the other specialties. But as you can see, by the end of ST7, ready to fly, independent in all of the capabilities. You may find that for the specialty curricula, such as ours in geriatric medicine, at ST4, you've got a lot more level 2s where you will need to provide more support and supervision to trainees just entering a new specialty. We were asked by Mike and Zoe perhaps to concentrate in this next section a little bit on the generic capabilities and how trainees might provide some evidence to their supervisors that they were meeting these generic capabilities. So Becky has drawn out 2 of the generic SIPs, and we're going to have just a wee bit of thought about how you might evidence these in your portfolio.
Yes. Just before we come into this, I think like when I hear our talk, when I hear about the signposting, because I think we're going to talk a lot about signposting within this part, signposting maybe makes people feel a bit apprehensive about actually how much work that might involve or what kind of thought process that has to involve, particularly at the beginning. If some people might feel like they have to summarize their whole curriculum. I think like it's about an overview of the levels that you're at in the SIPs, and actually that should be able to come with your self-rating alongside like with a line or 2 about why you think you're at that level, actually with not as much time as I think some people are fearing. But we are going to talk about signposting quite a lot even within this. So the first SIP though we're going to talk about is about being able to deal with ethical and legal issues related to clinical practice. Now the descriptors, I mean I don't need to read them out, but they include about your legal responsibilities, ethical requirements, saying sorry to patients, and ability to lead the clinical team in an open manner when things go wrong. And with regards to the descriptors, then each thing links to the GPC domains and also evidence. If you remember one thing from our talk, for me, I'd really like it to be that you don't have to have all these things to be approved for it. Equally, so you don't have to, on the slide before this, you don't have to have every single one of those descriptors within it. It's an overall holistic view, and there's some ideas about how the person might have it. So I think like I've been on call this weekend. I was just going to talk about a patient that I saw that came in with a fall, and that they, when I listened to their chest, I could see that they had a grade 3 sacral sore. And so I would like to do a CBD on that patient when I'm back at work. And I was thinking that when I do that, that would be a good kind of case that then I could say, I would really like us to do a CBD on that patient to talk about some of the clinical things, but also I wondered if also we could focus on some of the ethical and legal things that I did and that we could signpost within that. Because for me then, I think that I would be able to show you how I recognised it, how I knew to raise a safeguarding, how I knew to communicate that with other members of the MDT, and how I took some of the juniors with me to see and then talk about it. And I think that that's probably the best way to evidence some of these is often within a clinical case.
I think that's really important, and I think that demonstrates, Becky, why the GMC feel that these generic competencies are really important for the provision of good medical practice. Yeah. And for us as supervisors, I think we just need to think a little bit more holistically when we're completing those SLEs. So as you say, rather than just commenting on your clinical management of the patient, if we can try and remember which of the generic capabilities have also been demonstrated by your holistic management, and remember to focus on those as part of the SLE, which can then be used by you to link to pieces of evidence for that capability.
Yeah, so I guess it's like about what I've taken away from my understanding is to be a little bit more explicit about how you have met some of the more generic SIPs within some of your more clinical scenarios.
I think that's right, and perhaps as a supervisor it reminds me that I'm relatively good, I think, about commenting on communication skills as a more generic issue, but there are a lot more generic things like ethics and teaching and training and use of guidelines that we can also comment on in SLEs as well.
Yes, and of course there are non-clinical things as well, such as your M&M meetings referring to the coroner, complaint, things like that can also have their own one if required, but I do think they fit nicely with the clinical ones. And then so the other one was about carrying out research and managing data appropriately. Now there are lots of descriptors. As I say, you don't have to have all of these things. They're examples about how someone might be in a holistic manner. And they include things like research, about critical appraisal, about following guidelines, and about putting guidelines into practice. And you can see that, again, it shows you the GPC domains and how they link, and there's a lot of overlapping domains within the generic SIPs, and also about the evidence. The evidence quite similar, and of course, we all have to do our QIPs or audits within it. I think, again, with research, there are some easier ways, aren't there, to kind of link it. So if you do your good clinical practice course, you can talk about that. With your audits, you can talk about that. But again, also with cases, like I had a patient yesterday who came in with spontaneous bruising, and he is a paramedic and very well read, and he came with lots of resources from NICE guidelines about why he's taking his decabral for longer. And although it maybe wasn't my favourite time on call on a Sunday, it was good to be able to then go through some of that with him, and I guess that would be something maybe not as niche as that, but there are lots of times where you would talk to patients about the numbers or the reasons why you're making decisions, and just being a little bit more explicit about that. Also, I can think of times where I've been taught about asthma guidelines on training days, for example, and then putting them into practice and writing about that, how you might put it into practice.
I think that's right, and I think there are many ways that you can demonstrate these capabilities. Some of them might be going to a course, but others are very much more how you integrate guidelines, I think, into clinical practice. Again, quality improvement, yes, you do need to do 2 quality improvement projects, one for our specialty and one for internal medicine. So there are ways of developing those quality improvement capabilities through formal training, through informal training, and through actual practice as well. So I hope we have persuaded you very quickly that assessment of capabilities in practice involves looking across a range of different skills and behaviours. Clinical supervisors, so we are aware that for many deaneries and for many specialties, the educational supervisor may not be working directly with the trainee, and therefore the educational supervisor's link to the clinical supervisors is going to be key both through tools such as the multiple consultant report. The Rough Guide, which is a really helpful resource, talks about faculties, so getting local groups of consultants together to feed back a much more broad view of any particular trainee's progress, particularly if you don't know that trainee well, is also going to be really key, I think, in helping the educational supervisor come to an entrustment decision, because we do need to remember, as I think will be described in detail later on, there's educational supervisor's responsibility to indicate the level of entrustment for the ARCP. Talk very briefly about the Rough Guides. This is a really good resource. Every specialty has one. Do read that if you haven't already, because it will help you in that transition to the new curriculum. I would just like to say thank you to my specialist society, the British Geriatric Society, who've been really proactive in doing some webinars and developing resources, and thanks to Becky and the trainees for inputting into that. I suspect other specialist societies have similar resources to you, so look out there on the JRCPTB website, but also on your specialty society websites as well, because there's lots of information and resources out there.
So the frequently asked question live document that we have on the British Geriatric Society website doesn't just include geriatric medicine. There's questions that are updated regularly, and they're about a range of questions that I'm sure lots of other people ask, like about the linking of evidence, about acceleration, about who doesn't have to transition, who does, etc., all on there as well.
Thank you.